I'd like to thank all three presenters for sharing your experiences with us today. We have time to take questions from participants, so please, if you have a question for any of the presenters or any comments, please drop them in the chat box and we will start to take them right now. As the questions are coming in, I'd like to invite Dr. Cohen. Benita, I'd like to invite you just if you want to share a few thoughts to get us started on the discussion based off of all four presentations. Is there anything you'd like to highlight? Okay, so I'm going to take the first question from there. So we have a question coming in, and Tania, this is a question for you. So folks would like to know if you can provide any information on the local resources which you're currently examining. So you mentioned you're drawing on two pieces of work. So if you want to share that, then that would be great.
Sure. Thanks for your question, Victoria. So the main document that we're looking at is the City of Ottawa Public Engagement Strategy. So we're currently looking at that. They have some vision, they've got a vision and some guiding principles, public engagement spectrum as well. So we do have an Ottawa Public Health specific engagement toolkit that was done some time ago based off of that. So we're also looking at that and how we can maybe merge the two, and again, what needs to be updated, refreshed, and really focusing on Ottawa Public Health specific engagement examples that we can highlight.
Great, thanks for that. We have another question here, and this is a question which I think will be relevant for both Bernie and Shahram. So you're both researchers and you have a close connection with public health organizations. Can you talk about your relationship? And because I think it's an interesting piece around how organizations can enhance the capacity through partnerships with researchers. So what is the nature of your relationship?
Sandra, do you want me to start? So, hi everybody, this is Bernie. I can start. Just historically, there had been really close relationships built between researchers and public health leaders through a collaboration called the Renewal of Public Health Systems and Services that was actually led by Marjorie MacDonald and Trevor Hancock. And Trevor had been in the BC Ministry of Health when the research agenda around public health systems and services was conceptualized. And one key part of that was the work around health equity. So in many ways, my relationships with all of the health authority and ministry partners were built through that larger collaborative. And that collaborative, by the way, also included health units and public health in Ontario and Public Health Ontario. And it was built on the whole premise of, you know, if we're going to really do knowledge exchange and integrated knowledge exchange, we need to build kind of relationships between academics and leaders in the field. And so the ELPH project really was one of many projects within that collaborative. And, you know, I was really resonated with me when Tania was speaking about the changes, because one thing I think we came to realize is that there's just constant change of positions and leadership within the health authorities. And one of the most useful things is when those relationships are facilitated from one person to another. And I think, you know, in the province, we're now at the point where we have these really strong relationships that can kind of survive changes in people because we're now like 7 years into the ELPH project, more than a decade into it. So relationships are really core. And through some of those relationships with interior health specifically, and I'll turn it over to Sana here, to talk about, the way in which the medical officer of health, Trevor Cornell, had a vision for how the ELPH research could be translated into policy and practice. Over to you, Sana.
Yeah, thanks, Bernie. Yeah, and I'll start by saying I wrote in on the coattails of all the partnership work that Bernie and the ELPH team and Trevor and Marjorie had done. And then the really, I think, key part of my relationship with Interior Health has been the way the role has been structured. And so the reason we call it an embedded scholarship is because I am really and truly embedded into Interior Health. So I am part of the population health team. I'm also part of the research team. I sit in on all of their department meetings. So in terms of that piece around turnover and really trying to figure out who are your allies and who can you lean on, being there and being considered sort of one of them has been really integral to being able to do this work in a really applied way. And then importantly, as Bernie mentioned, Dr. Trevor Cornell, who's the Chief Medical Health Officer at Interior Health, he is the official sponsor of my role. And so having that type of sponsorship, it really gets you through a lot of doors. It gets you into senior leadership meetings, and it really gives you sort of a bit of buy-in before you start saying that. And then lastly, I think the really important piece is that all of the work that I've been doing and ELPH's been doing is we've been really, really purposeful and conscious of the fact that when we're speaking to our health system partners and when we're working with our partners, we're responding to their needs. And so we're not focusing on sort of the theoretical academic pieces, but we're really responding to the things that they've identified themselves as issues and really framing our research as being useful to those pieces, but also in some ways taking work off of their plate, because as we know, capacity issues are the #1 thing in health authorities. And so if you can really make the case of why the work you're doing is valuable and framing it within the language of your partner's work, so their metrics, their strategies, their deliverables, it really makes it go a lot further than when they see it as another thing that they have to be doing.
Great, thanks you both for that. So Benita, if you can speak and want to share some comments, this is the time to do so. Thank you.
Thanks. Can you hear me now?
Absolutely.
Wonderful. Sorry, I was talking and no one was hearing me before. I just wanted to say, well, I found it really interesting to hear everyone talk about their various perspectives on this. And something caught my eye. Diane Oikel wrote in the chat section, I recently heard the term relentless incrementalism in describing the pace of health equity work. And that was what I wanted to mention, that Sume talked about all the different elements of organizational capacity for health equity action. And it's really complex: governance, data, physical infrastructure, resources, partnerships and engagement, the workforce, the culture, and so on. And I think there is sometimes a tendency to feel overwhelmed and to think that if you don't have all capacity in all those areas, then you're never going to be able to achieve anything. And I love that idea of relentless incrementalism, because I think that organizational capacity is something that even if at a certain point in time all the sort of external forces are limiting you to one area of that work, I think that even changes in one area can often lead to changes in other areas, so that it's really important not to think that you have to have the capacity in all those areas to be successful, because I think that's just an overwhelming idea.
Great. Thanks for those comments, Benita. I think you're really speaking to the fact that I think Sana mentioned complex adaptive systems. So I think that the point you're making aligns very nicely with that. So thanks for those comments. We have time for 1 or 2 more questions. So if you have them, please send them in. So there's a question in there if you want to share that in the chat box and also for the speaker. So Diane also is interested in hearing thoughts on the idea of resources and time. We often think we need more resources and more time, but we are not likely to get more of either. Do we need instead to use the time and resources we currently have in a different way? I think that's a great question for all our presenters as a nice wrap-up. So I'm going to invite, we'll do it Bernie, Sarah, Tania, and Benita. Do we need to use the current resources in a different way, and if so, how exactly, in terms of organizational capacity?
First,
Can you get started? So the line is open, and that's a question for all four guests.
It's Tania here from Ottawa. I would say that I agree with Diane. We're not going to get more time or resources, so I think it's about priority setting and being realistic as to what we can do and what we can achieve, and what our priorities are and what we should be focusing on.
I think you hit it really clearly, Tania. It's about making health equity a priority, and that's a pretty significant shift. So in some ways, it's more the shifting in thinking. But if we go back historically and kind of look at some of the major reports that have been done about health systems, there's always been that push to reorientate health systems more towards in some cases, community care, public health, social determinants. You know, we've got those kinds of reports at the global level, like the Social Commission, but we've also got them at the national level, our national level, where, you know, various reports have pointed that we need those kinds of shifts. So it is shifting some priorities and some value shifts, which actually means we may reallocate money differently as well. And otherwise, and I didn't talk about this, but in our research, otherwise practitioners are doing what they called and what we called health equity work underground. They're just constantly trying to do things that are going to affect the determinants of health for the people they're working with without the systemic support. And they not only will they are burning out and leaving nursing. And we certainly heard this in our data, not just nursing, but leaving healthcare as well. So there's a very good reason for focusing on health equity and social determinants of health, and an argument around you know, the importance of this, not only for better health for people, but actually for your staff as well.
Yeah, and this is Sana. I'll just follow up on Bernie's point. What we found was really impactful in interior health, especially when we're speaking to senior leadership, is as opposed to sort of even saying that we need to change the priority, is actually starting from a place of saying, look, this is all the work that's already happening in your health authority that is health equity work, and really drawing on that and pointing to the fact that we're just trying to continue on the momentum that's already started, and really starting to point out that it's not that this work isn't happening, it's not that we're not paying attention to it, so it's not something extra, it's just that it's happening often in a non-coordinated way where we're not creating sort of the system response or supports that are necessary to keep it going forward. And so I think that in general, when you start from a perspective of positives or strengths, that you can usually get a lot further, as opposed to sort of, as you mentioned, Diane, framing it as we need resources or we need more time, but instead flipping it on its head and say, this is what we're doing, but we're doing it sometimes, as Bernie says, undercover, and which actually is in some ways inefficient. So how do we take what we're already doing, build on those strengths, and make it more coordinated and more purposeful? And so starting from a strengths-based point of view has always been very helpful.
Great. Thanks for that, Senna. And Benita, you have the last word.
Oh, well, I have nothing else to add other than I just love that positive strengths-based approach. Yeah, so I think it's a great way to end.
Great. Thank you. I'd like to thank you all so much for sharing your expertise with us today, and thanks to all our participants for joining us. The webinar recording is going to be available on our website, and following this webinar, we'll share any results that came through in the chat box. We will host our next webinar in this initiative on March 20th, so check out our website for more information on that. And please take a minute to complete the evaluation form right after this webinar. I also want to flag that the NCCDH recently relaunched and revitalized our Health Equity Clicks community. Asha Cortete, who is on the line, is our community manager and moderator. So please join Asha and the rest of the NCCDH team in the community. It's a great place to find out from your colleagues what's going on and to also share your own experience and expertise. Also on the site is upcoming webinars and events, so please do check those out. And as always, if you have any questions or comments, please feel free to reach out to myself or any other individuals on the team. And I think I'll speak for our presenters here. I think they'll be happy to answer any more questions